So good morning to you all. For those who missed me this morning in the sea, I had a swim from 7:15 until 7:45. And it was you who saw me swimming. Yeah, it was you. So there is proof and there are pictures, I know. And so tomorrow morning we have all a swim at 7:30. It's okay. When we talk about the ablation of thyroid cancer, again, this is probably one of the most important issues in this field. When we talk about the ablation of thyroid cancer, in fact, we're not ablating thyroid cancer, we're ablating a thyroid remnant. We're not ablating malignant tissue. That is, in fact, when the surgeon has done his work properly. He has resected all the malignant tissue, and there should be no malignant cells in the head and neck region anymore. The problem is, in some cases, and we heard it yesterday, the T3 state tumors, it might be very difficult to assess whether there are remnants or not. And that makes it difficult. And that is, in fact, the starting point for discussion. Why is it so important to know whether there are malignant cells or not? It has all to do with the uptake of radioiodine in cancer cells compared to normal cells. The first step of dedifferentiation of a thyroid cell, as mentioned yesterday, is that there is cancer induction, and that has consequences on the sodium iodine expression on the surface. Usually the expression is less optimal and its function is less optimal than in normal thyroid cells. And that means generally that in thyroid cancer cells, the uptake of radioiodine is less optimal than in the normal cells. And from that perspective, you can realize that the treatment of thyroid cancer requires higher activities than when you treat benign thyroid disorders. And that is the basic principle of ablation or treatment of thyroid cancer at the initial stage. I'm not talking about the dedifferentiation process that will be later on today, but we talk about this first step, thyroid cancer induction and an optimal treatment. Now, what in fact is the definition of iodine 131 ablation? It is written here, you can find it on internet. It's the systemic administration of iodine 131 for the selective irradiation of thyroid remnants, microscopic differentiated thyroid cancer, or other non-resectable or incompletely resectable differentiated thyroid cancer, or both purposes. And the question is, and that is really a semantic question, is ablation really including thyroid cancer treatment? To my opinion, if you talk about ablation, you talk about the selective irradiation of thyroid remnants, and when you are dealing with microscopic residual disease or other non-resectable disease, you're talking already about thyroid cancer treatment, and that's something completely different. When we talk about ablation of thyroid cancer or thyroid remnants, it is good to realize that there are some basic aspects related to that. And first of all, of course, is the risk profile of the tumor, but also the risk profile of the patient. We know age and other aspects, male gender, are important risk factors. And on the other hand, radioiodine. What do we know? What is the indication of radioiodine? And what is the activity we should use in clinical practice? When we go back to the prognostic parameters of thyroid cancer, they're all related to the chance of recurrence and cancer death. And it is good to realize that all prognostic or stratifications are based on recurrence rates and cancer death incidences in thyroid cancer. Now we know regarding the most important risk factors, age at diagnosis of thyroid cancer, tumor stage, male gender, but also delay in therapy and optimal surgical and medical management are highly correlated with the overall outcome of the patient. And when we look at the pathological risk factors, as already been shown by Xavier, capsular invasion, unencapsulated tumors, multifocality, lymph nodes, but also, of course, distant metastasis, vascular invasion, and the sclerosant variant. Now, the problem is, what is a high-risk patient? What are, in fact, the parameters that establish, in fact, or finally, the risk profile of the patient? And whom of you is using all parameters to assess the activity or to establish the activity? Who is using age to adjust the dose? But it's a risk factor. Patients younger than 16 years of age, it's a risk factor. And you see here certain histological subtypes, the large tumors or tumors in the head and neck region, not in the area of the thyroid gland. When you look at the available staging systems, it has all to do with prognostic stratification. And you see the number of staging systems that are currently available in clinical practice throughout the world. The EORTC, the AMOS, OSU, the American Thyroid Association risk stratification. There has been a test done on these staging systems, and what was found out was that the positive predictive value of the ETA guidelines or the risk stratification correlated the best with the overall outcome. And from that perspective, in fact, we should all follow the ETA guidelines. But the problem is we live in Europe. So how should we apply that? And you can see here the differences when you look at the overall thyroid cancer survival rates based on the different staging systems. Stage 1, 2, 3, based on clinical classification, the EORTC classification, 4 groups. The AIMS has only 2 groups, the low and the high. It's almost comparable to the European guidelines. And when you look at the MACIS guidelines or stratifications, you see here 1, 2, 3, and 4, and all representing different survival curves. One of the most important things when we talk about the treatment of thyroid cancer is the first step, thyroidectomy, as already shown in the previous presentations. And what you see here is that a near total thyroidectomy overall has a better outcome prognosis than when a near total, a less near total thyroidectomy has a less optimal outcome than in patients with a total or near total thyroidectomy. You have to realize that most of these figures or plots have been based on a combination of many risk groups. So be very careful when having a look at such data. But still, when you look at the data and literature, the overall, this overall aspect has not changed over the past years. We still know that a near total or total thyroidectomy is in fact the base for an optimal outcome. And also the application of radioiodine ablation. Why do we do that? Well, this is one of the studies by Marcel Stokkel in the previous century, and it was shown that the overall recurrence rate was much lower when applying radioiodine treatment than compared with the patients who did not undergo an ablation. So from these data, we know that overall the outcome is much better when applying the radioiodine ablation. But again, old studies probably including many, many risk groups, so be very careful when you read the data and literature. And what do we in fact really know about the outcome after radioiodine ablation? It is presented in this really nice review paper. And what you can see here is that the statistical benefit of ablation compared to non-ablation in relation to mortality was assessed to be non-significant in most of these studies. And in fact, it means that when you look at the data and literature, you can ablate whatever you want, but it is questionable when whether you improve the overall survival rate or not. And even when you look at the influence on the recurrence rate, you see that there are some controversies in literature. Of course, there are some studies indicating a benefit of radioiodine ablation, but when you look at the other studies, also from done in large study populations, you see that there was not a significant improvement observed in some of these studies. But again, you have to realize there are differences in study populations. Be very careful. When we talk about ablation and the chance on recurrence, it is good to realize, in fact, what we are treating. And as I told you, when we do an ablation, in fact, in clinical practice, we are ablating normal thyroid tissue. That is what we are doing. There was a nice paper by Verburg et al. Related to the success of ablation. And what was seen there is that, or observed, that in patients with a successful ablation after 6 to 12 months, had a much lower recurrence rate than patients who had an unsuccessful ablation. And then I'm going back to my first slide. Why do these patients have a much poorer outcome? To my opinion, and I had a discussion with Erik Verburg, is that this group comprised patients who had residual disease at the time point of ablation. And that means that when you go through follow-up, the uptake of radioiodine was less optimal. The dose applied in this group was less optimal due to the diminished uptake, probably in thyroid cancer cells that were missed at initial stage. It could not be proven in the study, but it is probably the explanation for the differences in outcome. So be very careful when you have a look at these studies, whether you are talking about an ablation of normal thyroid tissue or the combination of normal thyroid tissue and malignancy. The problem is that when you look at the risk profiles and the major factors impacting the decision-making in radioiodine remnant ablation, the American Thyroid Guidelines are presented in this table. And you can see the benefit, the expected benefit of radioiodine ablation for all these groups presented here in this table. Is there a decreased risk of that? Not for all subgroups. Only patients with a T3 tumor older than 45 years of age, and also the T4 tumors, distant metastasis when they are present at the initial stage, yes. So there seems to be a benefit to improve the overall survival outcome when applying radioiodine treatment in such subgroups. When you look at the decreased risk of recurrence, you see that most of the data are conflicting. There is no benefit in the small tumors, conflicting data in the T2 tumors, the T3 tumors when the patients are young, inadequate data in patients with any size, any age, minimal extrathyroidal extension, conflicting data, etc., etc. So it is still very difficult to make up your mind. That are the American guidelines. If we compare the American guidelines with the European one, you see one of the most important differences is that in the United States there are 3 groups: the low risk, the intermediate, and the high risk patient groups. Quite simply defined. When you look at the European risk stratification, there are also 3 risk groups, but it comprises a very, very low risk group, a low risk group, and a high risk group. So where is the intermediate risk group? What happened with all the patients? To my knowledge, I'm a bit worried about this strategy. I will show you later why. And based on the European guidelines, you see here the indications for ablation. When is radioiodine recommended and when is radioiodine ablation not recommended? Well, in fact, patients with unifocal cancer smaller than 1 centimeter in size, in diameter, without other risk factors, or patients with multifocal cancer when all foci are less than 1 centimeter in diameter, even in the contralateral lobe. And it means that all small lesions found in the thyroid gland, smaller than 1 centimeter of diameter, should not be ablated anymore. Who is doing that in clinical practice? When you know that it is a tumor less than 1 centimeter in diameter, and you know that there are micro tumors in the other lobe. You do. So you're following the guidelines. You're not following the guidelines. You do. It's really funny. That's what we call, and that's personalized medicine. To my opinion, is that when you are dealing with cancer, and you say to a patient with thyroid cancer, with small lesions in all the lobes, smaller than 1 centimeter in size, and you send them home, and you say, okay, you will be on the safe side. If I was the patient, I said, I would get rid of all the cancer, give me the ablation, and send me home. Or at least do a complete resection of the thyroid gland. But that is the guideline nowadays. Now, it is really funny because we have the European guidelines, we have the American guidelines, but maybe you have seen this paper in 2013 in the British Medical Journal that was on the systematic review of the clinical practice guidelines in the diagnosis and management of thyroid nodules, but also on thyroid cancer. It makes it more complicated. It's just to give you an overview of what's happening in Europe or worldwide. The American guidelines here, European guidelines, the British guidelines, the European, well, etc. There are so many guidelines. This is the Dutch guideline. And you see, here it starts with the treatment, indication for thyroidectomy, post-operative care, the indication of iodine 131 ablation. You see the differences, high-risk patients, a tumor more than 2 centimeter in diameter, 4 centimeter, etc., etc. It's confusing. It's all confusing what's happening worldwide. But that is clinical practice. And this was sent to me a couple of weeks ago by Savas. Difficulties in deciding whether to ablate patients with low or intermediate risk differentiated thyroid cancer. Do guidelines mainly apply in the centers that produce them? I agree with you. It's very, very difficult to apply the standard guidelines in clinical practice. And this has all to do with the first steps in thyroid cancer treatment. Was there a complete resection of the thyroid remnant? How good is your surgeon? What did the pathologist find? Was it really a good examination of the sample that has been resected? So be very careful. You can apply all the guidelines, but if you cannot rely on your surgeon or pathologist, it will be very, very hard to get optimal cure. Now, why is this so important? Why is it so important to know something about risk stratification? It has all to do with how much activity we should give, or if we should give activity. And you see here the risk profiles, low or very low, the intermediate group and the high group. And that was adapted from the GAMES risk stratification or whatever you want. When you look at the European guidelines, the old guidelines advised a dose between 1100 and 3700 megabecquerels. For the low risk group, the intermediate risk group had a higher activity, and in the high risk profile, well, of course, we have to give more radioiodine because the chance of having really thyroid cancer still in situ is very high, and that requires more activity than when there is, in fact, no risk on malignancy. When you go through these groups, these risk profiles, in fact, it's quite simple. When there is really a high risk on thyroid cancer in the body, either by lymph node metastasis or distant metastasis or whatever, you can use this, a high dose, without any question. That is not a problem. But there we go. The very low risk differentiated thyroid cancer. I told you, papillary thyroid cancer with a diameter less than 1 centimeter. 80% of the patients have a tumor in one lobe. but 20 to 25% of the patients have multiple foci and also bilateral spread. So be very careful of that. So you know that after a hemithyroidectomy, there may be thyroid cancer remnants in the other lobe left. Well, the standard indication for a very low risk differentiated thyroid cancer is lobectomy without ablation in case of a single or multiple foci, but the foci, the diameter of the other foci, should not be larger than 1 centimeter in size. In all other cases, there seems to be an indication for radioiodine therapy. Now, the discussion about what should we give for the other risk groups to the other patients. When you look at the data and literature, in which there was a comparison presented between the high and the low dose, we know, or we think, that there are a lot of data available in clinical practice in which this was prospectively analyzed. How many papers do you think have appeared on this topic in a prospective setting? Who says more than 20? You. Who says less than 20? You. Who says more than 100? Okay, I will show you. It's in fact embarrassing. It's one of the oldest treatments, radioiodine application. The prospective studies, the number of studies in which 30 millicurie was compared with 50 millicurie was 3. Only 3. When you look at 50 versus 100 millicurie, 1, 2. Both trials. And then 30 against 100 millicurie, also 3 studies. So overall, we're talking about, what is it, 8 studies. That's all. And what was found in literature, or based on this, is that there might be a slight tendency towards a high dose with a better outcome thereafter, but you have to realize that the confidence interval is important in this respect, and that was somewhere around 1. And that means that, in fact, there is no real benefit of applying a higher dose compared to a lower dose. The problem again, what was the patient selection in these groups? What was the risk profile of all these patients? And how was the success rate defined? Was it based on thyroglobulin and whole body scintigraphy, or was it a combination of thyroglobulin and ultrasonography? Was the golden standard used for this or not? And that was a matter of debate on these studies. Now, in the last 2-3 years, there were 2 nice papers presented. We call it, in fact, the Mallick study and the Schlumberger study. And they were both on patients with a low risk profile, or in fact, when you look at the American risk profiles, the low and the intermediate risk profiles. You all probably know these studies. And what was done in these studies was they compared 1100 megabecquerels versus 3,700 megabecquerels. You see here the study populations, the baseline characteristics of the patients. It's good to realize that T4, M1 patients were not included, so we're really dealing with low or intermediate risk patients. And you probably all know the outcome of this study. When you look at the success rate of ablation, in the Mallick study presented, there were no significant differences between the low and the high dose radioiodine. And also, when you compare thyroid hormone withdrawal and TSH stimulation, there were no significant differences observed in this study. But the follow-up was only 6 to 9 months. Keep that in mind. 6 to 9 months is rather short. You see here again, comparing other subgroups, the low-dose radioiodine plus TSH, well, etc., etc. In general, it doesn't matter what you use. It favors all the application of a rather low radioiodine dose. But what is the major comment of this? Persistent disease was diagnosed in 27 patients, and there we go. So there was thyroid cancer observed after 6 to 9 months. with the use of a post-ablation total body scanning, and neck ultrasonography or ultrasonography. And as specified in the protocol, data for these patients were excluded from main analysis. And that is the problem. How sure can you be before you apply the ablation that these patients are not in your study population? We have absolutely no idea. So these patients were initially regarded as patients having a low-risk profile, but in fact, they all moved to the high-risk group. Be very careful when you read such papers. The Schlumberger study, it was in fact comparable with the same outcome, favoring the use of 1100 megabecquerels. Again, you see here the data, the differences between low and high dose and recombinant TSH or hormone withdrawal. And in fact, it was a copy of the Mallick study with the same data, with the same population, etc. The comments: there were no signs of cancer at the time of ablation, but patients were excluded after ablation when there were, after 6 to 9 months, signs of recurrent thyroid cancer. The problem is also that both studies have a very, very short-term follow-up. What about the long-term outcome? The overall follow-up was less than 1 year. And one of the most important issues or indications for applying a low dose is that side effects should be minimized. And maybe you can achieve it by giving a lower dose. But you have to realize that most of the side effects are reversible after a year. And was it really, really improved by using or applying a lower dose? One of the most important comments is that dosimetry is completely missing in both studies. We have absolutely no idea the size of the remnants, the uptake of the remnants, etc., etc. So it is difficult to say something about calculated or fixed dose when we have a look at these papers. And the question, of course, is what is the prognosis when the overall risk profile is indeed very, very low? Do we have to ablate also low-risk patients, not a very low risk, but is there an indication when prognosis is good for radioiodine ablation? These two studies were on 1100 megabecquerel. When you look at the data and literature, especially from the Turkish study groups, you see that even lower doses, about 800 becquerels, can be applied, but it can only be applied when there are normal thyroid cells left in the neck. Why? Well, they show definitely good uptake. You will definitely achieve a good result. And I think that even with 370 megabecquerels, you may achieve complete ablation. But it depends on your surgeon, how good he was at the initial stage. Now, when we put the two studies in a new meta-analysis, you see here the Schlumberger study and the Mallick study, the overall numbers of studies comparing 1100 against 3,700 megabecquerels slightly increased. You see overall, and that has to do with the risk ratio, the confidence interval. In fact, there are no differences between the two activities, and that means that you can safely use 1100 megabecquerels. Safely. You have to realize that despite the lower activity, side effects are still present. Of course, significantly less than when you use the higher dose, but when you look at the lacrimal dysfunction, you see that there was no significant difference observed between the two activities. Nausea, neck pain, salivary dysfunction. Yes, of course, it was less frequently observed when applying a lower dose. But you have to realize that salivary dysfunction after a low dose as this, even with 3,700 megabecquerels, it may resolve after a year. So also the side effects presented in the papers are observations up to 9 months. Data thereafter are missing. The problem is that when you have a good look at the data presented in the two studies, they all had a low risk profile according to the European guidelines. But according to the American guidelines, it also included intermediate risk patients. And now it is becoming interesting because what is in fact the overall outcome of patients with an intermediate risk differentiated thyroid cancer. And this was really a nice paper that was presented. And what you see here is that they studied only patients that fulfilled the criteria for intermediate risk. And now you see what is happening. And now you see why a long-term follow-up is highly important. You see here the overall survival difference between patients who had undergone radioiodine ablation compared to those who did not have radioiodine ablation. This is the follow-up time up to 200 months. And it means that after a short time, you may observe a significant difference in outcome. The intermediate risk group. So that is probably the comment to the Schlumberger and the Mallick study. They included intermediate risk groups, but the follow-up was only less than 1 year. We're looking forward to the data that will appear over 10, 15, 20 years. And when you look at the risk profiles of patients with an age older than 65 years, you see also the difference. You see the difference at an earlier time interval. So if you use the patient risk factors, including combined with the use of radioiodine or not, you see that at an earlier stage you see already the significant differences appearing in these plots. And also here again, over time, the intermediate risk profile definitely shows differences, but you have to wait for that. Be very careful. Now, I think that is all about ablation, about the standard follow-up in differentiated thyroid cancer. It's quite simple. I already told you this week that when at the initial stage you do your work properly, you can follow up the patient with a stimulated thyroglobulin test and ultrasonography that after 6 to 12 months you have to assess whether you were successful with your ablation or not. If not, you have to redo the treatment. But the question is, what is the optimal amount of retreating a patient? What are you treating at that time point? Thyroid remnant or thyroid malignancy? What should we apply? There are no data really available in literature giving an answer to that question. What we normally do in clinical practice is that when there are remnants or when there is uptake or when the thyroglobulin level after 6 to 9 months is elevated, we give a high dose because the patient may change from a low risk profile to a high risk profile. And of course, after 4 to 7 days, you have to do a post-treatment scan to assess where the uptake is. Is it somewhere in a lymph node or is it in a thyroid remnant or whatever? Be very careful on that. And that is the question. What is the best time point to make or to establish the risk profile of a patient? Is it before ablation or is it after ablation? Well, here again, the diagnostic accuracy of all tests used in clinical practice. I will come back later to this slide. What other imaging options should we apply when there is no uptake of radioiodine anymore? To my knowledge, these imaging options should not be applied after 6 to 9 months. You can go straight forward to another radioiodine treatment. It is expensive and the overall yield, well, it's minimal. The only thing is ultrasonography. If you find macroscopic lesions after 6 to 9 months, it changes your treatment strategy. You have to do surgery and then, well, I'll come back later to that in my last presentation of today. So my final 2 slides. The role of nuclear medicine, it's very, very interesting in differentiated thyroid cancer. In diagnosing malignancy, the role is limited. Again, don't do scintigraphy in case of a normal functioning gland with a nodule. Put a needle in it and assess the outcome. In In treatment setting, well, we know that our role is related to the risk profiles. Radioiodine treatment remains important, but changes are coming, definitely. I'm not sure whether we will get back the intermediate risk profiles in Europe, but be very careful. So in intermediate and high-risk patients, yes, we should ablate. In very low-risk patients, no. But what about low risk? Be very careful when a patient has multifocal cancer and when there is a lesion of 0.9 millimeters. Is it a failure of measurement or is it really 0.9 millimeters? So is it a very low-risk patient or is it a low-risk patient? Very, very difficult. And finally, monitoring. There is no role at initial stage for nuclear medicine. Serum thyroglobulin levels stimulated can be measured in combination with ultrasonography of the neck. Only when there is doubt about your results, you may think about a diagnostic scan, but the diagnostic yield of the scan you use is very low. You definitely will miss lesions that are small or show low iodine uptake. Regarding the dose, well, again, I think in low-risk patients there are enough data that underline the use of rather low activity, 1100 megabecquerels. In fact, we are not allowed to talk about intermediate risk patients, but if we do that, what is the optimal activity? And in patients with a high-risk profile, well, the optimal activity presented in the guidelines is somewhere between 150 and 200 megabecquerels. Apply that in clinical practice and wait for new data that will definitely appear in the upcoming years. So it is a challenge, but in fact what is happening throughout the world is that the role is limited and even more limited in the upcoming years. Thank you very much.